Hello, Afro DXs. Today I'm so excited because we have another time where we learn at least one other thing. So today we are going to learn about carpal tunnel syndrome, and I will start by giving you a case. After the case, please pause and see what you think. So imagine you are in the clinic and you are seeing a 68-year-old female who is known to have diabetes and hypertension. Her HbA1c is 6.1, that was done last month. Her blood pressure is well controlled. She's on metformin and losartan H, and she comes in for a refill. So she also tells you she experiences pain and numbness of the right hand. And when she brought this up to one of the doctors previously, she was given pregabalin, but it didn't help. So when she told the doctor that pregabalin doesn't help, the dose of pregabalin was raised, but again she said she doesn't see any changes. So she tells you, what you think. Should you prescribe something else, or is it, what is the diagnosis? So I think most of you get this right. So carpal tunnel syndrome, like all other syndromes, this is a collection of signs and symptoms which are caused by median nerve compression as it passes through the carpal tunnel. Why is it important for you to understand about carpal tunnel syndrome? It's because this is the most common compressive mononeuropathy that is known. And some people are more likely to be affected by carpal tunnel syndrome compared to others. And these include the elderly, pregnant women, females. Actually, females are more likely to be affected by carpal tunnel syndrome compared to males, to a ratio of 3:1. Other groups include obese patients, diabetes, patient with rheumatoid arthritis or osteoarthritis, patient with amyloidosis, etc. So it will be unwise to talk about carpal tunnel syndrome without mentioning something about the anatomy of the median nerve, because the culprit here. So the median nerve is a bundle, and this bundle has a lot of separate individual nerve fibers. All these nerve fibers can be traced from nerve root C6, C7, C8, and T1. The median nerve has both sensory and motor parts. The sensory part of the median nerve supplies the thenar eminence of your palm and the first 3 fingers and a half. This means first, second, third, and half of these ring fingers. Also, it has the motor part, which supplies muscles of the forearm and the hand. So the carpal tunnel, as the name suggests, is a tunnel, and in this tunnel passes several things. One is the median nerve that we've talked about, and another are 9 flexor tendons of the fingers that you will flex the fingers. This tunnel is bordered superiorly by the transverse carpal ligament and inferiorly by the carpal bones. So the pathophysiology of carpal tunnel syndrome is an interesting one. It is known that there is increased pressure inside the intracarpal canal, which causes direct nerve injury or impairs the axonal transport or compresses the vessels that supply the nerve and causes nerve ischemia. What is not preciously known is what causes the increased pressure, but is thought to come from 2 things. One is anatomy, and 2 is inflammation. So anatomy, in a sense that there is increased volume of the contents inside the intracarpal canal. We're talking about things like these flexor tendons. But again, inflammation, in a sense that if you take these nerve fibers and the nerve bundle itself, there are layers surrounding these nerves, like they're called endoneurium or epineurium, depending on what they surround. And if you put these layers under the microscope and look at the blood vessels, you realize they are inflamed and they dematous. So when they dematous, they swell, they increase the pressure. So let's see how patients with carpal tunnel syndrome will present to you. So this patient will tell you they feel pain, numbness, and paresthesia to the part that is supplied by the carpal, by the median nerve, sorry. So that's what you read. But in real life, you will see patients who are saying it's not just on that part, but maybe the whole end or the tips of the finger, or just on the wrist. So they can all present like that. And the pain is mostly during the night. They'll tell you they woke up in the night, they find that they feel numb and they shake vigorously the hand, or they do this. Or it's when they put the hand in some sort of fraction of the wrist that they feel the symptoms. But in severe cases, patient will have continuous symptoms. They can also have weakness of the hand muscles that will interfere with some of the activities like cooking or laundry. The pain can radiate to the forearm or the shoulder, but it usually doesn't go beyond the shoulder. And when it does that, please consider other differential diagnosis. Again, 65% of this patient will complaining of bilateral symptoms, and that's why you see some people confusing this with peripheral neuropathy, but it's not, as we'll see later. So the diagnosis of carpal tunnel syndrome is purely clinical. It's purely clinical, but some people might consider doing nerve conduction test or EMG, maybe when you are very unsure if it's not carpal tunnel syndrome, or you think in the future, patient will benefit from surgery, because before they go to surgery, this patient, EMG must be done to see if they have a complete loss of innervation of the median nerve. So, in diagnosing carpal tunnel syndrome, you have different bedside test maneuvers that will help you diagnose this syndrome. The first one is called the Fallen test, and this you have your patient do like this. They'll hold their hands like this for 1 minute, and it is expected to reproduce the symptoms that they're saying. They say they're feeling pain or numb when they do that after 1 minute. Another is called Tinel test, where you'll hyperextend the wrist, and you'll be tapping on the carpal tunnel, and when you tap, patient will feel paresthesia going to the hand. The last one is the manual carpal compression, where you will compress for half a minute the carpal tunnel, and patient will say they feel the symptoms. So after diagnosing this disease, now you have to treat it. And treatment of carpal tunnel syndrome, it can be non-surgical or surgical depending on severity. So if the disease is mild to moderate, you can start with non-surgical measures. And these include prescribing a wrist support to patients that they'll be wearing them for every day when they go to sleep for 1 to 2 months. Another way of treating carpal tunnel syndrome, and this is a quick one for the patient that wants quick results. So you can inject the carpal tunnel with steroid, and here we use 20 to 40 milligram of methylprednisolone start dose, and they'll have a quick recovery of the symptoms. Alternatively, you can combine the wrist support plus oral steroid, and you can give maybe 10 to 20 milligram of prednisolone for a short course of 10 to 14 days. So some patients might need surgery, and these are the patients who have severe symptoms, or they've used non-surgical measures and they have failed. So when we say severe symptoms, we mean 3 things here. One is that patients have symptoms that interferes with their sleep, like they wake up every time when they sleep, they feel pain. So this patient will need surgery. Other group of patients is that they have continuous symptoms, not intermittent. All the time they feel pain, they feel numbness. They also need surgery. Another group is the patient that their hand functions have been interfered by the disease. Like they can no more do laundry as they used to do. They can't cook, so they also need surgery. And another group is the one which the the non-surgical measures have failed. But before any patient goes to surgery, they have to have an EMG and nerve conduction test before, to prove that there is complete axonal loss or there is loss of innervation of the median nerve before they go to surgery. If that's not the case, they'll be returned to continue with conservative measures before doing surgery. Many people confuse carpal tunnel syndrome with peripheral neuropathy, as what we saw in the case. I believe the doctor thought this is diabetic polyneuropathy and gave patient gabapentin, pregabalin. So pregabalin, gabapentin, NSAID, they don't work. They don't work. That's why you have to have a correct diagnosis before you treat it. And again, peripheral neuropathy is known to have two things. It's distal and it has 3 S's. It is sensory, it is slowly progressive, and it is symmetrical. It can't just arise from one hand or arise from one hand and go to another hand. You see patients complaining of numbness that is slowly progressive from the feet ascending and involving the hands later. Thank you very much. That's for today. Hope when you see this patient in your clinic and they are on pregabalin, you will take off that pregabalin and give them a wrist support. See you later.